Good evening all. Today I'll be covering the basics of post-operative management of heart and lung transplant recipients, and I've made the presentation brief and I've only covered the issues which are pertinent to intensive care unit management of these patients. First, let's come to the heart transplant, post-heart transplant patients. The principles of management are about these issues like hemodynamics, coagulation and bleeding, immunosuppression, mechanical ventilation and AKI, and other non-cardiac organ dysfunction. Regarding immunosuppression, I have not covered it intentionally because most of the time it is beyond the scope of management of a code intensivist. Just I'll say briefly a few things about it. Now, all the post-heart transplant patients, they come to the ICU and they are always intubated and requiring some amount of inotropic support for maintenance of their hemodynamics. So the reasons of requirement of hemodynamic support are several, like the newly transplanted heart which is denervated, and there is always some amount of ischemia and reperfusion injury in the harvested organ, and a cardiopulmonary bypass, usually a prolonged cardiopulmonary bypass, causes significant inflammatory reaction and hemodynamic alterations, and also to some extent myocardial injury, particularly when the myocardial protection is not optimum during the cardiopulmonary bypass, and the pulmonary artery hypertension. These often the pulmonary artery hypertension is pre-existent in the recipient. So these four factors which mostly determines the post-operative hemodynamic management, and that determines the requirement of hemodynamic support after surgery. Regarding the management of patients, before going into the management, let's discuss about the hemodynamic monitorings and their goals. So PA catheter is almost always used in heart transplant recipients. Obviously, a central venous catheter is required, and a continuous cardiac output monitoring device, be a PICO or a LEADCO, is usually used along with the PO catheter. And obviously, the other routine hemodynamic monitoring devices like arterial blood pressure, and some centers monitor EtCO2 also, and ECG and other common monitors, pulse oximeter, are routinely used. So from the PA catheter, usually a continuous measurement of the PA pressure and intermittent measurement of the pulmonary capillary wedge pressure, which is a surrogate of you all know that surrogate of left atrial pressure, are commonly used. And from the CVP, either it is the central venous pressure, the superior vena cava, or the right atrial pressure, which is commonly continuously used. Now the hemodynamic management has several components. First, as the newly transplanted heart, as it is denervated, so there is always absolute or relative bradycardia. So percutaneous atrial pressing is almost always required, and the heart rate is usually set around 100. So relative bradycardia is common in this group of patients, and pacing is probably the treatment of choice in this scenario. Next, coming to the inotropic support. As I have discussed, the requirement of inotrop is almost ubiquitous in these patients. So regarding the choice of inotropic drug, I am coming into it in detail later. And the patients usually requires a vasopressors also, because some amount of vasoplasia are also common in this group of patients. And in patients with elevated pulmonary artery pressure, so pulmonary vasodilators are also required. Let's come into the inotropic agents. These four inotropic agents are commonly used, like epinephrine, isoproterenol, milrinone, and dobutamine. Regarding the choice of inotropic agents, it depends upon their pharmacological profile and the patient's hemodynamic status. Isoproterenol, it has a good pulmonary vasodilatory action also, so it is being preferred in many centers. Non-adrenaline, though I have not mentioned in this list, and most of the intensive care unit is commonly used, but it's not chosen as a first inotropic agent in this group of patients, and it is mostly preferred as a vasopressor agents. So epinephrine, isoproterenol, they are commonly used. Milrinone can be used. It is also good pulmonary vasodilator action. It decreases both afterload and PVR also. But the main limitation of milrinone in this scenario is the hypotension. So in patients with isolated pulmonary hypertension without much hemodynamic instability, milrinone can be a good choice. Dobutamine can also be a good choice. It is a pure beta agonist, but the main issue with the dobutamine is just like epinephrine, is it causes significant tachycardia and it predisposes to arrhythmia. Regarding the vasopressors, it is a non-epinephrine and vasopressors are most commonly used along with the phenylephrine. Non-epinephrine also has some beta effect action, and the main problem that it increases the SVR and it may compromise the visceral perfusion, though mostly it's a theoretical concern, but still it needs to be taken care of. Vasopressin, though it's a non-catecholamine vasopressors, that is the most important difference from all other vasopressors that are used in clinical use, and it can cause to some extent intestinal vasoconstriction and may compromise visceral perfusion, and ischemic bowel is a concern in this patient. Phenylephrine can also be used, and remember, like vasopressin, though the mechanism action is different, it also doesn't have any positive inotropic action. Regarding vasoplegia, a good number of patients after cardiopulmonary bypass and heart transplant, they are in a state of profound systemic vasodilatation, which causes normal or elevated cardiac output and reduced blood pressure. So though the cardiac output is usually increased, but because of the profound vasoplegia, the ultimate tissue perfusion decreases. So there are several risk factors has been identified, right, like a high BMI or a body surface area, prolonged ischemia of the harvested organ, hypothyroidism, previous cardiac surgery, prolonged cardiopulmonary bypass. Sorry, it is not CPD, it has to be CPB, cardiopulmonary bypass. They are also identified as a risk factor. And as I have discussed, the alpha adrenergic agonists are used. Vasopressin can be used. Alpha adrenergic agonist, you can use both noradrenaline and phenylephrine. Vasopressin and the methylene blue has also been used with reasonable success in this group of patients. So if the hemodynamics is not acceptable even after use of optimum inotropic agent, vasopressors, and optimization of the filling pressures, that the both left atrial and right atrial filling pressures. So the mechanical circulatory supports has been used in this group of patients, like IABP, ECMO, and temporarily ventricular assist device. It may be LV or RV depending upon the clinical scenario has been used. Regarding IABP, it has the most of the intensive care, cardiac intensive care unit, they use it in patients with cardiogenic shock after acute myocardial infarction, but the evidence in support of its use is limited nowadays. ECMO is commonly used in these specific scenario, like post cardiac transplant patients, though the superiority of one device above is not fully delineated in previous studies. There is some evidence that ECMO, if it is required and if it is used, it might improve survival. But remember, the patients who require ECMO after heart transplant, they usually have a poorer prognosis, and the main problem with the ECMO is the anticoagulation. And second problems which is specific to in this group of patients, that ECMO may not provide an optimum LV unloading condition, so the LV oxygen demand might not be reduced with the ECMO, which is a benefit when IABP is used. Still, the evidence, probably some studies says ECMO may be a better option in this group of patients. Temporary assist device has been used, both LV and RV, depending upon the hemodynamic situation of the patient. Regarding arrhythmia, so post heart transplant patient, they are at risk of bradycardia. So because of the denervation of the heart and also the sinus node injury during the surgery and the ischemia, and supraventricular tachycardia is also common. Ventricular arrhythmias like VF and VTs are relatively uncommon. Remember, always if there is a new onset arrhythmia, be it a SVT or VT or BF, you should always search for a primary graft dysfunction and rejection. So that is an important point. At this point of time, you should talk with your transplant team and the immunologist regarding the possibility of rejection and graft dysfunction. So regarding the management of arrhythmias, the first thing is the optimization of the electrolytes, particularly the potassium and magnesiums. Pacing is mostly routinely done. Amiodarone can be used in cases of refractory cases, but whenever the amiodarone is used, you should remember the drug interaction, particularly with the calcineurin inhibitors. So amiodarone is not usually the preferred agent, but if it is required, you should remember the drug interaction. Calcium channel blockers and beta blockers, their use is limited because they cause a significant bradycardia. So until unless it is absolutely necessary and only in the specific clinical scenario, they are indicated. Regarding the post-operative mechanical ventilation, there is no studies has specifically addressed this issue. That the common practice is to avoid the hypercarbia and the respiratory acidosis, both of which increases the pulmonary vascular resistance. So prevention of the increase in PVR is important, and also the lung hyperinflation is avoided, as it also increases the PVR. Early extubation is desirable whenever the chest is closed after all bleedings are secured and the hemodynamic stability has been attained and the patients are normothermic. So per se, mechanical ventilations should not be prolonged beyond a day or two if everything goes uneventful, and it is mainly depends upon the hemodynamic stability of the patient and bleeding also. Regarding non-pulmonary or non-cardiac organ dysfunction, AKI is common after heart transplant. So the incidence may be, overall incidence may be up to 50% in various studies, and nearly 20% of the patients require renal replacement therapy. The optimum management of the cardiopulmonary bypass and the preservation of the heart and maintenance of the hemodynamics is probably the key to the prevention of AKI. But there are some data suggests that low dose atrial natriuretic peptide can also be protective. This data not very robust, but still there is some evidence that in cardiopulmonary bypass it has some protective effect. So another factor is important for AKI, like venous congestion. So venous congestion, when is defined when the right atrial pressure is more than 20, so that can contribute to the postoperative AKI, and probably ultrafiltration is of help. So the risk factors are identified in this group of patients, like impaired oxygen delivery, ischemia, venous congestion, and another important factor is the bleeding and the tamponade. Regarding bleeding and tamponade, one thing you must remember that cardiac tamponade after heart transplant may not always be detected in the transthoracic echocardiography if there is a accumulation of blood behind the heart, or it is a small lobulated accumulation. So it may not be possible to identify in the transthoracic echocardiography. So a high index of suspicion is required in case when there is a coagulopathy, and also hemodynamic compromise is which is suggestive of tamponade, and venous congestion must be avoided, and RV dysfunction is also a contributing factor to the postoperative AKI. Regarding the prophylaxis for infection, the CMV prophylaxis is indicated. The drug and dosage of the drug depend on the CMV seropositivity of the donor and the recipient. Pre-operative antibiotic prophylaxis is obviously indicated, and it should cover the Staphylococcus aureus species, and pneumocystis infection prophylaxis is also indicated, and prophylaxis for mucocutaneous candidiasis is routinely indicated in this group of patients. Next, come to the next topic discussion, like post-operative management of lung transplant recipients. So here the concerns are little different, like the primary graft dysfunction and ARDS-like picture, which is of utmost concern in this group of patients, and along with arrhythmia, infection, and other non-pulmonary organ failure. Now, what is primary graft dysfunction, PGD? Just before going into it, what is the principles of post-operative mechanical ventilation in this group of patients? Just for information, there is no study available which has specifically evaluated various ventilation strategies in this group of patients. So all the data are derived from a different group of patients. So lung protective ventilation, which is usually a tidal volume of 6 ml per kg body weight along with a PEEP, and limiting the plateau air pressure to less than 30 to 35. The older data says 35 is the principle of mechanical ventilation in this group of patients. And whenever a ventilation is being instituted, so our aim is to prevent the graft infection and also to prevent injury to the newly anastomosed bronchuses. So PEEP is usually used, but how much PEEP is to be used, it's difficult to identify because there is no data available. So it depends, it varies center to center. But remember, when there is a bronchial fistula is present, usually PEEP is avoided. So at this moment we don't know which is the optimum PEEP. Secondly, we don't know which is the optimum FiO2. So it is intuitive to accept the fact that the lowest possible FiO2 should be used, but how much is safe, or how above, whether any threshold is there above which the lung injury, risk of lung injury increases or not, that we don't know at this point of time. Regarding the primary graft dysfunction, so it is defined as a diffuse alveolar infiltrate along with a hypoxia. So it has been graded on the basis of pulmonary edema and FPF ratio or a oxygen saturation by FiO2 ratio. So it has been graded from 0 to 3. 3 is usually carries a very poor prognosis, and usually extracorporeal oxygen therapy is indicated in patients with grade 3. Regarding the gradation, so the gradation should be done 24 hours, 48 hours and 72 hours after the anastomosis of the second lung, for the perfusion of second lung. So whenever the second lung is perfused, so this is considered as the time 0. Then at 24 hours, 48 hours and 72 hours, the primary graft dysfunction should be assessed. And at 72 hours, if there is a pulmonary primary graft dysfunction, it is the most important, it is of most important clinical significance. Now, what are the risk factors? Various risk factors has been identified for PGD, like a smoking history of the donor, allograft size mismatch, ischemic injury of the harvested organ, and obesity. They has been identified as the risk factor for primary graft dysfunction. So regarding management, regarding ventilatory management, there is no established method. So lung protective ventilation is the as of now is considered the standard of care. Conservative fluid therapy may be of help, though no robust data is available. Conventionally, CVB is kept less than 7. Inhaled nitrous oxide or prostacyclin may be of some benefit, but though there is no robust data is available. 𝑬𝒑𝒂𝒓𝒄 or a 𝑉O-ECMO, depending upon the hemodynamics of the patients and the cardiac function, is mostly required in patients with primary graft dysfunction of grade 3. Next, coming to the arrhythmia, these patients are at risk of arrhythmia, particularly the atrial arrhythmias are common, and the incidence may be as high as 45% or more. And there are a lot of controversies whether the atrial arrhythmias after lung transplant are benign or they have they attribute to the post-operative hospital stay and mortality. The recent data suggests that atrial arrhythmias after transplant are not truly benign. They contribute to both mortality and post-operative hospital stay. So various risk factors again has been identified, mostly are non-modifiable, but identification of the risk factors is important, like age, male sex, history of previous arrhythmia, history of hypertension, coronary artery disease, dyslipidemia, and intraoperative inotropic use, and the postoperative inotropic use also. So regarding the management and the prevention, the volume overload has to be avoided. It is always detrimental, as we all know. It is not only the arrhythmia, it contributes to the post-op AKI also. Beta blocker and calcium channel blocker can be used depending upon the type of arrhythmia. When patients are hemodynamically unstable, cardioversion is the treatment of choice. Rhythm controls usually are not a preferred modality of arrhythmia management, particularly atrial arrhythmia management, until and unless the rate control is ineffective. So anticoagulation is required, but particularly in cases of recurrent or persistent atrial arrhythmias like atrial fibrillation or atrial flutter, but surgical bleeding risks has to be taken care when anticoagulation is started. Regarding infectious complications, the second leading cause of mortality after graft dysfunction in this group of patients, which may be as high as 20% in the first month. So pneumonia is the commonest infection in this group of patients. So in the immediate post-operative period, it is usually the organisms which come from the donor lung contribute to the pneumonia. And bloodstream, the management of pneumonia in this group of patients is similar. You start with a broad spectrum antibiotic, and if culture positivity is available, the antibiotic may be chosen, or it may be chosen according to the culture sensitivity data. Bloodstream infection is also not uncommon. Its incidence is overall incidence around 10%, and it carries a significant mortality at maybe up to 25%. Viral pneumonia, it's relatively uncommon in this group of patients in the immediate post-op period. Next, coming to the fungal infection, overall infection incidence is not very high. It's around 10%, 8.6% at 1 year. So it is more common after 90 days of transplant, not in the first one, 90 days to 12 months. Aspergillus is the commonest infection, followed by the Candida, and Aspergillus infection usually takes place at the site of bronchial anastomosis. So Candida infection can be there, particularly in the first one, and antifungal prophylaxis is usually indicated. There are several surgical complications which also needs to be taken care of, like a post-operative hemorrhage, large airway complication that includes bronchial anastomotic dehiscence or a fistula, and the vascular complication that includes kinking and thrombosis of the newly anastomosed vascular and vessels. So two things I have in this lecture I have intentionally avoided, that the management of rejection and the management of or the commonly used drugs for immunosuppression. So whatever it depends upon the institute to institute. Usually a steroid, calcineurin inhibitor and mycophenolate muflate combination is used. So our most important concern is that whenever some drug is used in the intensive care unit, be it an antibiotic, be it amiodarone, so the drug interaction has to be taken care of, so that the concentration of the particularly the calcineurin inhibitor like tacrolimus should not be too much high, so that the post-operative kidney dysfunction, risk of kidney dysfunction increases. So this much I have covered in this lecture, and these are the references which may be of interest to all of you, and thank you.